An introduction to critical care, presented by me, your host, Pat Nelligan. The patient is septic and the blood pressure is low. I think they have septic shock. What am I going to do? In this tutorial, I'm going to look at fluid resuscitation of the patient in septic shock and when to use vasopressors, what pressors to use, and how to adjust them. Cardiovascular assessment, the blood pressure, septic shock. This tutorial will look at one of the most devastating causes of shock that we see in clinical practice, that is septic shock. It's a disorder that claims the lives of countless victims each year. Many of these deaths are avoidable, and thankfully the care of the septic patient has improved immensely over the past 2 decades. This tutorial will look at the ways that we understand septic shock, that's the pathogenesis, screening for it, identifying that patient, and then managing the patient with septic shock based on the standards that have been set by the Surviving Sepsis campaign. We'll start with a number of clinical scenarios to frame the problem. Maeve is 76 years old. She has a 2-day history of feeling unwell. She's now confused and has a temperature of 39 degrees Celsius. Her blood pressure is 80/40 and her mean arterial pressure is 55 millimeters of mercury. She has foul-smelling urine. This is an easy diagnosis. Maeve has a urinary tract infection. But it's not always this easy. Brian is a 22-year-old college student who felt unwell while working in a coffee shop. He called his GP and he was referred to the emergency department complaining of headache, nausea and vomiting, and pyrexia. He was sent home after 4 hours. Following discharge from the ED, he continued to deteriorate by the hour. He kept vomiting, and then red spots appeared on his back and his neck became rigid. He returned to the hospital 7 hours later and ended up in the ICU, intubated and ventilated on high-dose vasopressors. Unfortunately, Brian died of multi-organ failure, and his post-mortem diagnosis was meningococcemia. Now, this is a sad and characteristic story. If you read the newspapers, every year you'll come across several of these stories, and it usually goes like this. A relatively young patient presents to the emergency department complaining of unusual pain or symptoms. The overworked ED department doctors or nurses, maybe they're under-trained, perhaps they have very little experience, but they decide that it's probably a viral illness or there's nothing much going on, or even worse, that it's psychosomatic. Standard blood tests and investigations are not performed, or if they are performed, nobody chases up the results. The patient is sent home, then the patient continues to deteriorate, and they arrive back critically ill and then are transferred to the ICU. At this stage, it's the spin of a dice. Patients may recover or they may die. And that death was preventable if the patient's sepsis had been identified at an earlier stage. Frank is a 69-year-old farmer who cut his arm on a rock a couple of days ago. It became sore and throbby. The general practitioner prescribed oral antibiotics, but Frank became listless and confused. He stopped passing urine a couple of days ago and his wife brought him into the ED. When he came to the ED, he was confused and hypotensive and tachycardic, and his legs were mottled and his left arm was swollen. And it's important to understand that sepsis is a systemic disease and it's manifest by organ injury distant to the site of infection. In Frank's case, he has a necrotizing soft tissue infection of his arm, but he's coming in with low blood pressure, confusion, and oliguria. He is in multi-organ failure and his potential mortality rate is extremely high. Sandra is 42 years old and she delivered her first baby vaginally 2 days ago but needed an episiotomy. She went home yesterday. Today, Sandra is very confused. She's talking nonsense and she's seeing things. Her husband is worried and he brings her back into the ED. When she comes in, her heart rate is 96, her blood pressure 96/50. It's not particularly low in the setting of the peripartum period. Her respiratory rate is 22. She's seen by an obstetric resident who diagnoses postpartum psychosis and admits Sandra to the ward and consults psychiatry. 6 hours later, Sandra is found moribund in the bed. She is blue all over. Her heart rate is 150. Her blood pressure is 60/40. Her fingers and toes are black. This is purpura fulminans. And she has group A streptococcus growing from her episiotomy site. Again, this is a characteristic picture that you see with relatively young patients. They get sick, they're symptomatic, they're doing okay, their vitals look more or less okay, and then they fall off a cliff. And it's so important to identify this at an earlier stage, because with sepsis that gets to this stage where the patient has septic shock and multi-organ dysfunction, you are looking at a 50% mortality rate, and it is not improving. If it's diagnosed early, the mortality rate is extremely low. But when patients get into the state that we have seen in each one of these cases, the mortality rate is really high. In terms of definitions, they're only sort of helpful. The current definition of sepsis is that it is a life-threatening organ dysfunction due to a dysregulated host response to infection. I'll explain this in a minute. Septic shock, by the way, currently is defined as a subset of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities occur that substantially increase mortality. For someone like me who manages patients with sepsis, these definitions are tremendous because I understand them. But for the average person out there, they are just gobbledygook. And I think that the easiest way to think about septic shock is very simple. It usually means that fluid therapy in the setting of someone with an infection has failed to increase the mean arterial pressure above 65 millimeters of mercury, and vasopressors are required. Now let's take a quick look at the pathophysiology of sepsis. The onset of septic shock usually begins with the introduction of a pathogen, usually a bacteria, into the bloodstream or tissues. The immune system detects these pathogens via pattern recognition receptors, such as toe-like receptors or nod-like receptors that are present on immune cells like macrophages, dendritic cells, or neutrophils. These receptors recognize pathogen-associated molecular patterns. These are known as PAMPs, and damage-associated molecular patterns, DAMPs. These trigger an innate immune response. Once the infection is recognized, a cascade of signaling events is initiated, leading to the production of pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukins 1, 6, and 8, and interferons. This subsequently activates complement, phagocytosis, and coagulation, and there is a full cellular immune response with T cells, B cells, and neutrophils subsequently. Eventually, a third level of response, the adaptive immune response that produces immunoglobulins, occurs. How this works over time is as follows. We have our pathogen that binds to the toll-like receptors, and this activates that early innate immune response. Then there is a secondary cellular response, that's the T cells and B cells, and then of course that adaptive response, the antibodies and the immunoglobulins. Simultaneously, there is an anti-inflammatory response that is built to cool down this entire system, and that mirrors the pro-inflammatory response. Now, unfortunately, sometimes that inflammatory response burns itself out and the patient develops a state of immunoparalysis, whereby all of the inflammatory tissue is used up, there may be excessive anti-inflammatory activity, and the patient loses the ability to inflame. And this is really important because in septic shock, what we seem to have is this excessive inflammatory response where there is widespread tissue damage, and because of that, there is devastating injury to the endothelium of the vascular tree. The capillaries become leaky, the glycocalyx is damaged, protein-rich fluid extravasates into the extremities, causing widespread tissue edema. there's an abundance of coagulation, clot is deposited in the microcirculation, and flow is poor. But the thing is, when you have this huge amount of inflammation, there is a devastating loss of inflammatory tissue and a loss of inflammatory reserve. And as a consequence of that, the patient is subsequently a sitting duck for secondary and tertiary infections. So septic shock should be seen as dysregulated inflammation. The normal inflammatory response does not function normally. Often there is devastating release of inflammatory activity, damaging and activating the endothelium, leading to thrombosis and damage to the glycocalyx with capillary leak syndrome. There is the release of inducible nitric oxide synthetase, bradykinin, prostacyclin, and various other things that cause vasoplegia. Vasoplegia means pathological vasodilatation. There's coagulopathy and endothelial damage causing microcirculatory disruption and organ failure. The immune dysregulation results from massive release of both anti and pro-inflammatory cytokines. The immune system becomes paralyzed and susceptible to opportunistic infection. There is dysfunction of the mitochondria. There's dysregulated metabolism. The autonomic nervous system becomes completely dysfunctional. How do we identify that the patient has become septic? Well, we need a screening system. If you look at our 4 patients, they all had similar complaints. They were all septic, but not all their symptoms were the same. And the key part of managing the patient with septic shock is to identify that and then commence empiric therapy and ensure that there is adequate tissue blood flow to ensure homeostasis and prevent further organ failure. In the process, we're going to control the source of the infection. So how do we identify patients with sepsis? I'm quite fond of this particular approach using the mnemonic sepsis. S for slurred speech or confusion, E for extreme shivering or muscle pain, P for passing no urine, S for severe breathlessness, I for it feels like you are going to die, and S for skin mottled or discolored. Really good. Now we have screening systems in our hospitals, and there are 3 different screening systems that are used. One of them is the quick SOFA score that I'm going to mention in a minute. This came out in 2016, but it's no longer recommended. Then there are the SIRS criteria that derive from the mid-1990s. They are a little bit problematic and dated, but most hospitals still use them. And then there are the early warning scores that are used in most hospitals to screen, for example, for sepsis or acute deterioration or acute critical illness in ward patients. And I find these particularly useful in our clinical practice. Just to explain the SIRS or Systemic Inflammatory Response Syndrome definitions or criteria. SIRS is 2 or more of the following: temperature of more than 38 or lower than 36, a heart rate of more than 90, a respiratory rate of more than 20 breaths per minute or acute hypocarbia, a high white cell count or a low white cell count. So 2 of those, and then evidence of infection. And to this, I would add acute confusion. And these criteria have been very robust for picking up sepsis over many years, and there's a lot more to them, and I would refer them to your local hospital protocols for sepsis screening. The quick SOFA score was brought in to rapidly identify a septic patient, and SOFA means sequential organ failure assessment. I'll get back to that in a minute as well, because there's a lot more to SOFA than just the scoring system. But this identified sepsis quickly using 2 of the following: altered mental status, a respiratory rate of more than 22, or systolic blood pressure of less than 100. So 2 of these plus a suspected infection is sepsis until otherwise proven. Unfortunately, not everyone who's septic has 2 of the 3 things, and that's why it has proven to be neither sensitive nor specific, but as a quick rule of thumb, I think it's pretty good. So when we're looking at our septic patient, it starts off with an infection, and that leads to sepsis, which is dysregulated inflammation. Ultimately, that proceeds to septic shock, where the blood pressure drops. There's hypoperfusion to the extremities. The patient becomes oliguric and becomes confused, and ultimately that leads to multi-organ failure and death. And if you look at the different timelines, infection, if it's picked up early, is associated with a relatively modest mortality rate, but the mortality rate increases exponentially as one goes down this list. So how do we manage this? Well, for infection, usually we give patients oral antibiotics. That's what our patient with the inflamed arm was given. But they're not always effective enough because of tissue penetration problems. And that's why when patients develop sepsis, they must be given intravenous high-dose antibiotics. If the patient develops septic shock, they're given intravenous antibiotics, they're given intravenous fluids and vasopressors. And if they develop multi-organ failure, they're in the ICU receiving mechanical ventilation and often kidney replacement therapy. I will point out that if you think that the patient is infected or septic, give them broad spectrum antibiotics now. It's easy to stop antibiotics. Treat first and do the workup simultaneously or later. Now, this number is quoted in the literature. It's a little bit controversial, but I think it's a good number to keep in the back of your head, that for every 1 hour delay in antibiotic therapy, the mortality rate increases by up to 7%. And that comes from a paper in Critical Care Medicine in 2014. As I previously mentioned, septic shock is sepsis with hypotension that does not respond to fluid resuscitation requiring vasopressors. That is a state of vasoplegia, or pathological vasodilatation. Most doctors only think of vasodilatation being in the arterioles, but 66% of vessels are veins, so a major component of this is in the veins. There is a dramatic increase in the unstressed blood volume. Because of a reduction in venous return and often a problem with cardiac contractility, there is a reduction in stroke volume. Right down in the microcirculation, there is dysfunction of the capillary endothelial glycocalyx. Because that's disrupted, there is clotting in the microcirculation, and that is the motor of multi-organ failure. So we've hypotension, slow capillary refill time. So if you squeeze the finger, it takes ages for blood to flow back in. There's not infrequently mottling of the knees, the blue knee sign in the extremities, and there is evidence of severe stress that is manifest by hyperglycemia and hyperlactatemia, meaning lactic acidosis. In terms of multi-organ failure, what are we looking for? In the cardiovascular system, hypotension and hypoperfusion, vasoplegia. In the brain, confusion, delirium, coma. In the respiratory system, hypoxic respiratory failure, going on to acute respiratory distress syndrome. In the kidneys, oliguria and acute kidney injury. In the GI tract, the liver, ileus, hypoglycemia, hyperbilirubinemia. In the blood and the immune system, coagulopathy and thrombocytopenia. Now, this can be quantified using the sequential organ failure assessment score, the SOFA score of 0 to 24. I'm not going to go through this in detail, but each one of these systems has a score that goes from 0 to 4, and you can calculate out the SOFA score. The higher the score, the less likely it is that the patient will survive. Virtually all screening systems that look at sepsis use the serum lactate as a way of quantifying how sick the patient is, because there is a direct correlation between hyperlactatemia and adverse outcomes in acute critical illness. And the reason for this is because lactate production is accelerated in the presence of epinephrine or adrenaline. The conventional wisdom is that glucose is broken down to pyruvate in the presence of oxygen, and that feeds oxaloacetate in the Krebs cycle. However, in situations where there is low oxygen tension or stress or huge activation of beta receptors, lots of that pyruvate is converted to lactate, or the lactate is never converted to pyruvate. because of activation of the lactate dehydrogenase enzyme by epinephrine, adrenaline, and there is stress hyperlactatemia. Sometimes this is known as aerobic glycolysis because the oxygen delivery to the tissues may be completely normal or actually high, but there is very, very high levels of lactate. So the way I looked at lactate is that the lactate level correlates with the level of stress and hyperadrenergic activity. Now we make a lot of lactate per day. We make 1.5 moles of lactate per day, and most of that is converted to pyruvate, or it's converted back to glucose by the Cori cycle and then broken down to carbon dioxide and water eventually. In states of hypoperfusion, there is increased production of lactate and there is reduced metabolism. So there is reduced washout or clearance. Most of the time, lactate is undetectable in plasma. The reason why is that it's cleared so fast by the liver. It's ejected from the cells and passes all the way up to the liver, and it's rapidly reconverted by gluconeogenesis to glucose, otherwise known as the Cori cycle. I'm going to use an analogy of a supermarket and the checkouts at a supermarket to look at the processing of lactate. So most of the time you can't measure lactate, but in certain circumstances the production of lactate increases a lot. For example, if you decide to run the marathon, you'll produce a lot of lactate. And that lactate is a very useful fuel source for the body. It can be used pretty much by any organ system in the body. But it does build up and it does begin to overwhelm the checkout operators. And indeed, the more lactate there is, the bigger the queue at the checkouts. Think about what happens at the holidays or at Christmas, where you can have huge lines at the checkout. And the rate limiting step is the liver itself that has to process that lactate back into glucose and ultimately to carbon dioxide. The liver has a limited processing capacity, and it can be easily overwhelmed in situations where vast quantities of lactate are being produced. So when the lactate is rising, it means one of two things. It means that the lactate production has gone up, and it likely also means that the lactate metabolism has gone down. So we have a problem of increased production. That's evidence that the patient is getting sicker because they're hypercatabolic and they're generating a lot of lactate being driven by epinephrine or adrenaline. And there is reduced clearance because the liver either isn't getting enough blood flow to clear the lactate, or else the liver is dysfunctional itself. Irrespective, a high lactate is a good marker of acute critical illness. It tells you that the patient is not doing well. And a lactate that remains high despite resuscitation and vasopressors is a bad prognostic sign in critical illness. If the lactate goes up and stays up, or even worse, continues to rise, that is a really bad sign that patients aren't going to do well. I will just point one last thing out about lactate. It really isn't a particularly good endpoint of resuscitation. There is a belief that by giving patients loads and loads of fluids that the lactate will clear faster, but that's only the case if the circulation remains unstressed. Once hepatic blood flow is reestablished, by giving additional fluids, venous hypertension arises. Then you get all kinds of problems with edema in the extremities and also in the bowel, and that actually might slow down lactic clearance because of flow across the liver being delayed by venous hypertension. Irrespective, now that we know our patient is septic, it's time to work the problem and treat the patient. Step 1. As soon as you see a patient that you suspect has sepsis, you need to put in an IV line immediately, and from that line take blood cultures to send to the lab and a blood sample for inflammatory response, that's a CRP or a procalcitonin, a full blood count, particularly the white cell count, and a plasma lactate. A lactate of more than 2 is always concerning. The second step, once you have put that IV in, is to give the patient broad spectrum antibiotics based on your best guess as the source of the infection. You can always narrow down the spectrum afterwards. You should also give the patient, unless contraindicated, 30 mils per kilo of balanced fluid. And when I say balanced fluid, I'm talking about lactated ringers or Hartmann solution or Plasma-Lyte, not isotonic saline solution. There is accumulating evidence that high volumes of saline are likely harmful to patients in septic shock. However, if it's the only fluid you have available, give it. Step 3. If the patient's mean arterial pressure is below 65 millimeters of mercury after giving fluid, then the patient needs vasopressors, preferably noradrenaline, norepinephrine. Adrenaline or epinephrine is okay, dopamine is okay, norepinephrine is the treatment of choice. Do not give the patient phenylephrine. There are compelling data that phenylephrine in the setting of septic shock is associated with worse outcomes than norepinephrine. Do not worry about central venous access. Pressors can be given peripherally in a vein that's proximal, such as in the antecubital fossa, or in mini boluses until a central line has been placed. In my view, you should not wait for a central line before you give vasopressors. Again, an emerging body of evidence suggests that early vasopressors are associated with better outcomes in septic shock. Norepinephrine is principally an alpha-1 adrenoceptor agonist in the extremities, and that means it vasoconstricts venules and arterioles, increasing the stress blood volume, increasing venous return. But it also principally increases diastolic blood pressure, increasing coronary perfusion. It is a very, very potent inotrope. It's as good an inotrope as epinephrine or adrenaline. Now, most textbooks will tell you that norepinephrine does not increase the cardiac output as much as adrenaline, but there's a reason for this. Epinephrine is a very potent chronotrope, so it not only has an inotropic effect, but it also increases heart rate. But that is not something we want to be seeing in sepsis, because our septic patient will often have a heart rate in excess of 100, so we give norepinephrine. The other benefit of norepinephrine over epinephrine is that it doesn't have any metabolic effect. It doesn't drive up blood glucose and it doesn't drive up blood lactate. So we can follow our lactate to see how the patient's stress response is going. Step 4. If the dose of norepinephrine is escalating, then the patient needs a second vasopressor drug, and the vasopressor of choice is vasopressin or arginine vasopressin. This is hormone replacement therapy, and a single non-titrated infusion at 0.03 units per minute is given to the patient. It's my view that this should be continued all the way along until you've started to wean norepinephrine, and indeed I do not discontinue vasopressin in my practice until the norepinephrine has been weaned off. Vasopressin is produced in the hypothalamus, but it passes down into the posterior pituitary before it enters the bloodstream. And it's usually activated by an increase in extracellular fluid osmolality or activation of the renin-angiotensin-aldosterone axis or the adrenergic system. The production of vasopressin has two effects. It works on V1 receptors to cause vasoconstriction in arterioles and venules. That increases the stress blood volume, but also because it's antidiuretic hormone, it increases plasma volume. As a consequence of both of these, there is increase in blood pressure. In sepsis, there is relative and absolute deficiency of vasopressin. In the early phase, there is massive release of all agents responsible for maintaining homeostasis, including cortisol, glucagon, and insulin. And with depletion of particularly vasopressin, the body develops a vasoplegic state that is resistant to catecholamines. There may also be vasopressin resistance because of the high level of circulating initial vasopressin, resulting in downregulation of both V1 and V2 receptors. Vasopressin replacement therapy, which is very, very low dose. This is not the dose of vasopressin that you're going to use, for example, for bleeding esophageal varices. This is purely hormone replacement therapy. It restores vascular tone, improving blood pressure and tissue blood flow without adverse effects. It is blood pressure for nothing. You do not see ischemic complications with this extremely low dose of vasopressin. The impact, though, in septic shock is that it reduces the required dose of norepinephrine. It's a synergistic effect, and the associated complications of norepinephrine, that's mottling and hypoperfusion in a very dysregulated microcirculation, are reduced. So if your patient is mottled, they should be on vasopressin. It also improves renal perfusion and increases urinary output by reducing renal arteriolar vasodilatation. Another thing to consider that if the patient is on high-dose vasopressors, you should consider giving corticosteroids, usually 50 milligrams every 6 hours. There are certain situations, for example, community-acquired pneumonia, where you should consider giving corticosteroids early. Step 5. Look for the source. The source is either medical or surgical. The common medical sources are the respiratory tract and the urinary tract. But the one you should always consider in a patient who's an inpatient are catheter-related bloodstream infections. That's an infected central line or portacath. With surgical infections, consider a wound infection in post-op patient or dehiscence. Otherwise, consider necrotizing soft tissue infections, pancreatitis, or cholangitis. In terms of the workup, you need to do a full culture workup very early. Blood cultures, sputum cultures, urinary cultures, a chest x-ray. And then, based on your suspicion, after discussion, selective imaging of the body. And that would be a CT of the thorax, abdomen, pelvis, etc. It's imperative to understand, though, that you cannot medically manage a surgical problem. And our patient who cut his arm with a throbbing arm will need extensive tissue debridement. You need to consult surgeons early. Step 6. If the mean arterial pressure is less than 65 with increasing multiple dose of pressors, you need to consider an alternative diagnosis. For example, cardiogenic shock, the patient should have an echo, or neurogenic shock, has the patient had a brain injury? Consider a CT of the brain. But there are other things to consider. For example, compartment syndromes, chest compartment syndrome, cardiac tamponade, pneumothorax, or excessive levels of PEEP interfering with venous return. And of course, in any patient who's had a large volume of fluid, who's on vasopressors, who's oliguric, whose airway pressures are high, consider abdominal compartment syndrome. If the lactate does not fall, consider bowel ischemia, splanchnic hypoperfusion, which may have been caused by fluid overload or excess vasopressors. Sometimes you'll see a hyperlactemia purely from an epinephrine or adrenaline infusion or from unresolved sepsis. If there is severe mottling, consider reducing the MAP target. So if the patient's mottling on high-dose norepinephrine, just let the pressure sag a bit to try and get some flow into that system, because the norepinephrine is hurting the patient, not helping the patient. So reduce that dose and then consider more aggressive volume resuscitation. In that setting, I think it's not unreasonable to give the patient hyperoncotic, that's 20% albumin, or plasma, or indeed blood products. This remains quite controversial, but most doctors in this particular setting will go ahead and give the patient albumin. Step 7. Once we've got our patient reasonably stable on pressors with antibiotics, it's really important to consider all the other potential complications that patients may have. So you need to be careful of fluid overload and acute kidney injury. Fluid overload itself can cause acute kidney injury. Acute kidney injury in sepsis is multifactorial. The patient may develop delirium and then subsequently develop post-traumatic stress disorder. They may develop ARDS from fluid overload, from inflammation from sepsis, but also from ventilator-induced lung injury. They may develop stress ulceration of their stomach, bed sores, and indeed malnutrition, loss of physiologic reserve, and indeed neuropathy of critical illness. Patients need to be mobilized early to prevent this. Step 8. Consider early deresuscitation of the patient. Watch fluid balance carefully. Aim for an even balance by day 7, full nutrition by day 7, minimal sedation, and antibiotic de-escalation based on the positive cultures that you have. Get rid of that broad spectrum stuff and narrow the spectrum down. Remember, these antibiotics are going to adversely affect the gut microbiome. Step 9. Start rehab early. Address sleep hygiene and circadian rhythms. Have the physiotherapists involved at an early stage and start mobilizing the patient. Have occupational therapy, seeing the patient from the very beginning, preventing foot drop, putting on splints, making sure that the patient doesn't develop pressure sores. If the patient has a tracheostomy, speech therapy is really important at an early stage, and the patient will almost certainly require psychological support while they recover from critical illness. Step 10. If the patient is not getting better, they are getting worse. Failure to recover should require you to consider inadequate source control, secondary infections such as respiratory tract infection, urinary tract infection, catheter-related bloodstream infections. Look for evidence of autonomic dysfunction. If a patient has been lying in a bed for 2 or 3 days, their autonomic nervous system may become haywired, and it's often extremely difficult to treat. Should also consider neuroendocrine burnout and look at the various different endocrine systems. Consider using corticosteroids late in critical illness if you're having trouble getting patients off vasopressors. I would recommend that everybody read the most recent version of the Surviving Sepsis guidelines. This is the current version at the time of making this video. It may have been superseded more recently. It's an extremely good document. It's really well done, and it's full of excellent data and recommendations. So let's review this tutorial. Early detection and antibiotics are essential to saving lives in sepsis. A high clinical suspicion is required in patients who are going off or have escalating early warning scores. Vasopressors are being used earlier in sepsis than before, and you cannot medically manage a surgical problem. I hope you're enjoying these tutorials. If you are, please subscribe on YouTube, leave me some likes and some comments, introduce me to some of your colleagues or friends, and follow my blog at ccmtutorials.org.